A very good afternoon, namaste, and greetings from NatHealth. I, Chirag, along from the entire secretariat team, welcome all the viewers who have joined with us live today, and also the eminent speakers who has managed their time from their tight schedule to make it happen. Today in our expert series, we will try to reimagine the next generation of human resource in the healthcare industry. Like other developing countries, India faces manifold challenges in meeting the demand for human resource in healthcare. Human healthcare, human resource in healthcare is an important component for reforms which have not received much attention despite the fact that WHO have been upfront advocating such measures for several years. Let us see what the industry experts has to say. Today, in our expert panel, I would like to welcome our first speaker, Ms. Nanki Singh. Nanki Singh is the founder and the CEO of ProTribe Smart Wellness for Senior. Nanki has been a part of the financial service industries in various roles in India and abroad for over a decade. She previously worked for the Royal Bank of Canada, CIBC, and Religare Financial Services, and then moved on to establishing a boutique transaction advisory firm specializing in healthcare. It is in this capacity Nanki realized a growing need of senior care and the gap in operational expertise available in India to serve of almost around 150 million population growing at 3.8% annually. This realization and the long-term vision inspired Nanki to enable a strategic collaboration with Genesis Healthcare, which now is ProTribe Seniors. As the CEO and the founder of a Sunrise Sector initiative, Nanki understands the straddle between operations, management, strategy, capital requirements, government licensing, and developing symbiotic business relationship while keeping a view and handle on the revenue growth. Nanki is also the General Council member of NATHEALTH, Healthcare Federation of India, and also the founder member of the Senior Care and Rehabilitation Vertical of NATHEALTH. Heartily welcome to the Expert Series, Nanki.
Thank you, Chirag. That was quite an introduction. I think, anyway, let's move on. And thank you for having us here. I do have, being on the operations side of the business and taking care of many seniors, I think this is a very important topic of discussion. And all of us as operators would know the intricacies of why and how this entire bill that has come up, which is most talked about nowadays, should work. And we will have in-depth discussions, I guess, on the entire concept. So yes, thank you very much for getting me on board.
Welcome, ma'am. So moving to our next speaker. Our next speaker in our expert series is Mr. Pradeep Sen, a co-founder of Cura Foot and Tebika Care. Pradeep brings around 25 years of experience in sales management, distribution, product management, and marketing, in leadership roles across industries, banking, FMCG, technology, and insurance, and geographies all from ranging from India, USA, and UK. He's experiencing in launching a new and large initiatives from the inception. Pradeep managed a commercial bank for 9 countries in Europe and then went to head the Global Receivables Services Bank in Citibank. Pradeep has worked in Titan Industries, Citibank, and JP Morgan Chase. Now he has co-funded 2 startups in India. He was based out of London. Since 2014, Pradeep has returned to India and given up his corporate life to co-fund and launch 2 startups, both compassionate for the healthcare sector. Happy to board you in, Mr. Pradeep. Heartily welcomes to our expert series.
Thanks a lot, Chirag. Looking forward to this.
Thank you. So moving to our third speaker in our expert series, we have Professor Ajay Vamadevan from Goa Institute of Management. Professor Ajay holds a doctoral degree from the University of London and teaches courses on advancement in healthcare technologies and healthcare information. Professor Ajay has over 20 years of experience in developing digital health. His keen interest lies on the cardiovascular disease prevention and management interventions. He has authored 60 scholarly papers and 10 books. Heartily welcome to the expert series, sir.
Thank you, Chirag, for having me here. Look forward to this discussion.
Absolutely, it's a pleasure. So let us initiate our expert series. From the quote, "Education is the backbone of our nation," we would like to initiate our expert series from Dr. Ajay, representing Voyager Management. Dr. Ajay, I would like you to give your insights on the vital roles of educational institutes to upscale the healthcare industry. Over to you.
Thank you, Chirag. So let me begin with a very positive note. In the last 7-8 years, Indian medical education has been able to pull through a major turnaround. We are able to double the number of MBBS seats to an annual intake of around 1 lakh through 650 medical colleges in India. Postgraduate seats have doubled more than from 31,000 to 75,000 over a period of 7 years. And this achievements has been as a result of the constant effort to meet the WHO requirements recommended doctor population ratio. So we have currently 1.3 million allopathic practitioners registered with the various medical council. So that comes to exactly one medical doctor per population. But if you include the other systems of medicine doctors, which is around 5.6 lakh, we are able to reach close to around 1.5 to 1.8, which is very promising. And however, so the required the recommended value of 1:1,000 is almost met in 2018. This statistics, if you compare with the developed nations such as Australia or France, is very low because their proportion is more than 3 per 1,000. If you compare with the BRICS nation, Brazil is having a doctor population ratio of 2. China is again at the rate of 2:1,000. Only South Africa is lagging behind us with 0.8 doctors per 1,000 population. However, we are happy that we are able to meet the WHO recommendation. But when it comes to paramedics, we have around 3.3 million nursing personnel, which include nurses, ANMs, auxiliary midwives. And their ratio, we are able to achieve only 1.96 nurses per 1,000 population. And the recommended WHO recommendation is at least 3 nurses per 1,000 population. And we are lagging a lot. And we face migration of the nursing staff to Middle East, Europe, and America. And there are gross imbalance across the geographies, across the states. The southern states perform better in terms of the doctor nurses density compared to the northern states. But the future must be promising because the government is keen in increasing the number of seats across medical as well as paramedics. The challenge is that the public health system is not recruiting specialists and the nursing staff for the rural population where we see the actual demand. However, moving forward, we should be focusing more on quality of the education and the distribution. Healthcare is not just doctors and nurses, it is multidisciplinary and evolving. So in that context, if we think about the role of education institutions, there are 5 system level factors that drive the role of or shape the role of institution, the educational institutions in meeting the emerging needs of the healthcare practitioner. So what I mean by healthcare practitioner is not just limited to doctors or nurses, but the interdisciplinary personnels that are required for the healthcare industry. So let's see one by one. The first and foremost is the science and technological developments that are happening. We see great strides in the engineering, science, and domains, and it is driving the emergence of new modalities of healthcare diagnosis and treatment. And the integration of new technological developments into educational programs provide the starting points of incorporating these innovations into routine practices. So what we see recently is the application of AI/ML, blockchain, robotics, nanomedicine, and so on, revolutionizing the healthcare. In the domain of basic science, we see huge changes in genomics, omics, lab on chip, organ on chip, and pharma research happening. And many of these technologies have the capability to transform healthcare in the form of personalized medicine, new digital therapeutics coming into the industry. And these are buzzwords that we hear. So the actual care provision in future is going to become interdisciplinary, and the universities need to focus on developing this interdisciplinary domain to build capacity of multiple practitioners, or capacity building across starting from research to practice. So so in addition to this research domain, we also face a shortage of trained professionals in health economics, health insurance, behavior science, population science, and many of these disciplines are required for increasing the efficiency and safety of healthcare, and we don't have good programs in this domain. Another change that we see is that the requirement of huge professionals in the domain of healthcare informatics and healthcare analytics, because we are moving towards a digital info which is pushed through the National Digital Health Mission, and there are other evolving areas like medical tourism. So our education system need to focus on these emergent skills or competency requirements for healthcare practitioners. The second driver is the national and international healthcare trends. The pandemic has taught us that infectious diseases have no border, and we need the requirement of new competencies to forecast, diagnose, treat, and rehabilitate, rehabilitation and prevention capabilities for addressing pandemics. So, so our educational institutions need to focus on many other disciplines, including animal health, agriculture and food systems, supply chain, environment, to tackle these emerging the threats from the infectious disease. The sad point is that we don't have good programs, training programs on biostatistics and epidemiology in this country, where the institutions, educational institutions, has to focus. Third driver is the public interest and needs. As we evolve, the country economically prosper, the aspirations differ. People will demand high-end care, personalized care, and more innovative approaches in healthcare. For example, we see many specialist hospital chains coming up. Home-based care is going to get a lot of attention and traction. So in response to these needs, the skills, the scope of practice and competencies required for these by the healthcare practitioners, our education system need to evolve to address or developing tailored programs for these emerging needs. The fourth driver is the population demographics and needs. For example, in India, we are undergoing a huge, a vast change in demography and epidemiological change in a short, compressed time frame. We are facing a triple burden, I would say. The infectious diseases are not receded fully. The non-communicable diseases are emerging. There is both malnutrition and obesity simultaneously in the population, and there is a geographical variation as well. Southern states are aging compared to northern states. So large urban population has moved into nuclear families, and nobody is take care of the elderly. So geriatric care becomes a major demand in cities. So one of our speakers, I believe, is going to speak about the geriatric care. And we need a special training for doctors, paramedics, nutritionists, physiotherapists to address these kind of emerging requirements. Perhaps we would require a tailored program for raising a special cadre to address these needs. And the final or the fifth driver is evolving human resource climate. The working conditions, patterns of the existing practice, they have the potential to alter the human resource landscape. So we find newer specialties evolving. See, for example, there was only cardiology. Now pediatric cardiology is coming up, and neonatology in medicine. Then even within pulmonology, there are even pediatric pulmonology is coming. So there are aspirations within the healthcare practitioners to align to such trends by acquiring trends and training and skills in this evolving discipline. The universities need to respond to these demands for newer programs and discipline. The other skills requirement is actually to meet the national health priorities. For example, we need training programs to on managerial and leadership competencies across the range of various healthcare and allied disciplines. So in summary, the education institutions have a lead role in meeting the needs for the ever-evolving healthcare industry. They need to be vigilant to the requirement of the requirements from the emerging 5 system factors that are driving, and the education institution need to identify, evaluate, and bridge the gaps in the capacity gaps to meet the supply and demand. Over to you, Chirag.
Thank you, Dr. Ajay. That was very insightful. And you gave a 360 view of whatever thing is going on right now in healthcare. Thank you for your insights. So moving on to our next speaker, I would like to invite Nanki. So ma'am, I would request you to give your insights on the requirement of elderly care professionals in the healthcare industry now in India.
Thank you, Chirag. I'm going to actually take a step back. The way I think about this process is, let's talk about the population. Fine, we are talking about a big number of 330 million by 2050, 20% of the population, all that is there. But we also have to further dissect this population into perhaps young, old, and the oldest old. So you have that segment. First, you have the old segment, then you have a segment within that. And then post that, you have to see where and what are the key focus areas that we need to really spend our time on as the senior care industry is in its nascent stages, right? And and then we'll go on to manpower, because for each of these key focus areas, we need manpower. We need awareness, we need quality assurance, right? So I'm not only going to talk about just the allied healthcare workers, which is an important part. I will talk about the larger requirement of manpower, right? So first is, of course, regulatory and policy reforms. We all know what that is. We know the government needs to work towards it. The government is working towards it. We need to have a national portal in place. I can go on and on about the requirements here, right? The government, I think, is still finding its feet in terms of synergizing who and how is going to take on what role. Apart from the government, there has to be private sector. So there has to be private public partnership. And then, so that is basically either to operate in quality assurance in that segment. Then you get onto the financing of care. The financing of care, which is close to zero right now for senior citizens, there is none. We are trying to introduce some insurance products, but right now it is still close to zero, other than your own personal income, and maybe your kids help out. Tax subsidies help here, but there again, no systematic way of really counting on those tax subsidies to finance senior population. And then I think the last place would be that we should really have a focus on aging in place, supported by a home environment, a community support system, a larger ecosystem on the welfare of the elderly, right? And so all of this requires manpower. All of this requires trained eyes. It requires processes. It requires us to really open up the profession of senior care in India in all its aspects. Finance professionals, teachers, geriatricians, social workers, banking professionals. Within the government also, there should be specialized people who understand this segment to be able to take this forward. And of course, the actual feet on street who really do deliver the product and care are your allied healthcare workers. Huge scope of improvement, huge scope of actually building that out. And as an operator, we face the crux of it and the backlash of it as well. We are looking at so much of the young population as well that is unemployed, that could actually be streamlined and roped into allied professionals. Give them a sense of security, give them a sense of what they can do and achieve in their professions. For example, if you are an attendant and have been an attendant for the last 10, 15 odd years, or a caregiver, give them a fast track system of becoming a nurse. They may not have to go through the entire 3 years of training, but a good system for them to be able to do a 1-year course or a crash course. That way they see professional growth for themselves. The key and the backbone of the senior care industry is going to be your attendants and your caregivers, not even nurses. Nurses only come in when there's a medical clinical need. It's and that's my opinion. I would love for the others to weigh in, but really it's your attendants who really get into your house, and apart from the practical knowledge that they have, they also need to have social skills to go and live in somebody's house, because the moment they go into somebody's house, you are a part of that family. You are in and out and privy to everything that goes on to that family. So social etiquette is very important. Education is very important. Right amount of training, on ground practical training is important. Within that, there can be specialization. Now, specialization amongst the 3 age brackets that I mentioned, and further specialization amongst skilled nursing, assisted living, long-term care, memory care, short-term rehab. So there is so much scope to actually design this entire matrix for your attendants first, then your nursing staff, and then your geriatricians and your general physicians, to actually learn and grow and make this profession not just a social cause, an actual for-profit, interesting profession which people would like to grow and see themselves proudly as a part of, would be my thought. Thank you.
Thank you, Ms. Nanki, for your keen insights on that. Moving forward to our next speaker, I would like to request Mr. Pradeep Sen to give his thoughts on how upscaling can improve patient care in home healthcare. Over to you, Pradeep.
Thanks, chirag. Right, I think Ajay, as well as Nanki, has really set the stage up for me, right? Because Ajay spoke about actually all the different what's really happening in the industry, and that there's a huge shortfall. Nanki again spoke about elder care, and I totally agree with her saying that it is the ayah or the attendant who's probably the most critical person in the elder care space, right? And that's the manpower that we have to skill, we have to upskill. So my topic is about upskilling, but when you think about elder care, home care, there's nothing like upskilling because no one has been skilled, right? You can only upskill when someone has already been skilled. just taking a few things that I think both that, Ajay said as well as Nanki said, 20% of India is going to be senior in about 15, 20 years, 2040. Again, when you break that down, 10% of that will be actually really elderly, so 75 plus probably, which means to say that you have only 9 young people for every really old person. And of them, a lot would be children. And because India is doing very well, everyone will have jobs. So you don't even have the associated, family taking care of elderly, what was happening, right? So suddenly when you look at it, you realize that in about 15 years, the same stuff that's happening in Japan or in the UK is going to happen in India, right? And we don't realize it today is because today you look at an elderly person, especially in the middle class elderly person, has not one, but probably 2 or 3 caregivers surrounding, driver, someone else coming, family, right in the next room, next door to them. That is all going to change. Nuclear families, people getting jobs, all of that will change. And suddenly you will have a situation in about 15 years. And this is where the curve really goes up, where you will have fewer people, and you have a lot of old people, right, on the other side. So where upskilling comes in, I think, is that we need to be a lot more effective. We need to be a lot more efficient in the way we do things. Like I said, India today is like what happened in the UK in the 1970s, right? In the UK in the 1970s, there were some people who used to do caregiving. Those people were supposed to do everything in the home. Exactly, the elderly person will say that I want ABC. They would do that ABC. There was no really training that was out there. And over the last 50 years, what's happened is that they were forced to actually adopt a lot of skilling, a lot of specialization. And then you had actually groups like, people who understand dementia very well, people who understand end of life care, people who understand things like incontinence, right? Adult diapers, incontinence, and all of that. Cancer care at home, daily living issues. So you had specialized people coming in. And the reason that they came in is because that's the only way with fewer people that they could manage, right? You don't have the luxury of a person staying in the home for 12 hours or 14 hours. And therefore, a person would come for 2 hours, do the stuff, and then walk away, right? And that's the way that they've done it. And to an extent, I think they've done good for the people that they had, right? And I lived there for a few years, so I've seen that, firsthand. So that works very well. So then what has really happened, So is it that the upskilling has worked, or is it something else, right? So is it the upskilling to the last mile care worker that has worked? Or has the full ecosystem sort of developed in which people are trained at different levels that it has worked very well? And Professor Ajay Vamadevan used the term interdisciplinary. I think that really it is actually, when you look at it, it's a 2x2 matrix. The people who are there got trained better. And then you have people with specialization who came in, and there was this interdisciplinary way that you started looking at elder care or home care, even at home. In the past, what we have been used to is, ek aaya ghar pe hai, and that's about what home care is or elder care is. That whole thing is changing. And to some extent, that's the same change that we have seen within Tribeca in India, right? So Tribeca, I started it about 10 years back. So I'm one of the old hands in the elder care industry. By far, we are probably the largest in this sector in Eastern India. Understand to it quite well. But I think that story, the way that we developed training, we obviously did not have the wisdom of Professor Ajay, Vamadevan, or Nanki at that time. So we sort of muddled through a lot of things, trying to figure out what's the best way to do it. The first thing that we tried to do was to take the attendants, ayahs, whatever you call them, and start giving them training. But then we realized very quickly that the ayah who's there is a person who's doing that job not because she wants to do the job, but because that's the only job she has, right? Or she'll get. And she's not the person, and when we think of skilling, we think of putting people in a classroom and then train them, give them some, presentation slides, and they understand it and they go back and do it. And you do that for a few days, and it doesn't work with this section, right? So you need a lot of different things that you need to do for them. And it's small things like including, how do you actually get the people to wear adult diapers? How do you get people to set up, right? The GTA system wasn't very good at that time. At the same time, what we started doing was, telling them how to use a phone, how to use, call up on an SOS number. How do you actually smile when you give the tea, right? So it's a lot of the soft skills as well as the slightly more harder skills that we started trying to put together. And very quickly, we realized that we are like a rat running on the same wheel, because these people keep moving out, and then you have another person after 4 months, you train them again, and they're not interested, and then you move on. And then we realized that, 2-3 years of that, and we're exactly at the same spot. What do? I think what we then did is what, Ajay mentioned, is interdisciplinary. And that's when we got a lot more graduates, but other people who wanted to be in the industry, and we started training them about dementia, training them about other things that they had. But you got a lot of the nurses, and not really the full-term BSc nurse, because BSc nurses are not going to work at home, right? You got a lot of other people to become the supervisors who would then go and manage and sort of do training at home and tell people how to do it, right? And we created a cohort of people who were supervisors who knew certain things very, very well, and they would go and sort of make that change in that home. To Nanki's point, what we then did, and if you come down to Tribeca today, we've created an entire set of people who would have probably become doing sales jobs somewhere else, or being, doing Swiggy or Uber drivers and so on. And suddenly they are in a profession that they like, they're into care, they're into a noble profession, and actually doing the work that they enjoy doing, right? So these are the specialists that we sort of created within the industry. And, and these are all graduates with, geriatric training that we have imparted to them over the last so many years, that we sort of use to create people, whether it's skilling, upskilling, and that is when the industry gets created. Once you create that, I think what happens then is you land up with another problem, which is about coordination, communication, and so on. And that is another nut we have to crack. This is where technology comes in. And I also run a foot care business. And one of the things the word that I've used in the past, and I use it a lot more right now, is the word orthotics and prosthetics, right? Prosthetics are basically stuff when someone does not have a leg, they use a prosthetic, and then they become they come back to normal. In a lot of cases, like let's say Iron Man's case, he wears that stuff and he becomes Iron Man, he becomes stronger than what he is. So to an extent, what technology has done with the care workers and all of that, is you suddenly have monitoring tools at home, right? So now you get the end care worker, which is the attendant that you have. You tell him how to do the monitoring, and then how do you record small little changes in the person. You press a button and you do something, and that will then trigger something. And then you have people in the office who's looking at that. And suddenly the entire disciplinary stuff using technology becomes a lot more robust, right? So SOS devices where you press a button, right? Monitoring tools like we spoke about, right? And a lot of people are using it for home care. So now when you take the existing people that you have, train them on very specific items, right? You train them on monitoring and observing people, and then giving that job to someone else to then figure out, saying that I observe this and therefore what should be done, and you have someone calling them up and saying, do X, Y, Z. That is when the interdisciplinary works. But here you're working with the existing IR that was there at home, right? I think so. So it's a combination of technology, of specialization, of getting different people with skill sets to actually help, and creating the circle of care that through which you can actually provide care to an elderly person, especially in the home care, right? Home care and elder care is very, very important, and I'm absolutely firm in my belief, saying that it's probably a lot more important than the episodic care that you see in the hospital. So you get into a meeting and you'll always see the hospital CEO being the star of the show, while the home care guys are right at the back and no one really wants to listen to them. But in my point of view, when you actually see what home care and elder care does, right? They touch the patient for a good, not 1 year or 2 years, but maybe for 10 years or 15 years and longer. They are the ones who make sure that you stay out of hospital. And that is the role that the elder care and home care person has. And that is what the IR, the attendant, and these care workers are actually providing. I think Nanki mentioned a very important thing, right? So you take an existing nurse and you try to put, she's worked in a hospital and you try to put them at home. Will she be a success? Possibly no, because what you need at home is a person who has confidence, the person who is doing a lot of different things and is able to make a call at that time, right? As against a nurse in a hospital or even a doctor, junior doctor in a hospital, who has the hierarchy to fall back on in a hospital or in a diagnostic or in a clinic setup. So here you're actually creating people who can look at that situation, make small calls, but now they're aided by people around them in offices like the specialist workforce that we have. And it is this team that is actually creating the care that you need. And I think that if the right people, people like Ajay, people like Nanki, people, who are thinking through these problems, getting the right solution for the caregivers, helping them figure out in a very, very not highfalutin, stuff that's there in the NHS, but figuring out what makes sense for India. And then getting your caregivers trained, upskilled, right technology, which is cheap and easy to get. When we are old, and I'm going to be senior very, very quickly, when we are all old, 15, 20 years, whenever it is, I'm sure that we will have the people who are going to take care of us even in our 70s and 80s, right? So it's not going to be all doom and gloom, but it's going to be a combination of people, technology, specialists who's actually going to take care of us in our homes. So that's my 2 bits on this, chirag. So over to you again now.
Thank you, Pradeep, for your insights. So we are moving to the second half of the session. So before we move to the second half of the session, we would like to start up with a quote. What is now proved was once imagined. I hope these insights that our experts bring to the table will contribute to the cause. So moving to the second half of the session, we have certain questions from the audience pool. The first question is for Dr. Ajay. Dr. Ajay, this one's for you. Digital tool and online education, what are the opportunities and potential? Over to you, Dr. Ajay.
So, the digital tool, online education, that has been a proven solution for in recent times for addressing acute manpower or addressing training needs in many settings. We have used that in the pandemic for training the healthcare workforce. And even this program right now we are having is online mode, which is becoming the norm of the current era. And there are startups that are coming, for example, Upgrad, Skill SR, and these institutions are getting tie-up with educational institutions and universities to offer programs for a wider range of to a wider range of audience, and specifically in the medical domain, like computer vision, augmented reality. There are such techniques which can be effectively used for training medical professionals, even without the use of them coming to lab or other sophisticated techniques. So I would say digital tools, online education, these are going to be a promising method for equipping or training manpower in the future. Over to you, Chirag.
Thank you, Dr. Ajay, for your feedback. The next question we have in our audience, from our audience, is for Pradeep. So you have been in the quality home care sector. So what are the critical challenges for maintaining quality care in home health care? So over to you, Pradeep.
Well, when it comes to home care, I think there are challenges. There are always challenges in this sector. The biggest, I think, is the one in which we don't have resources, right? So to get people, so if hospitals don't have nurses, if hospitals don't have doctors, why would there be people, that many nurses and so on in the hospital setup, right? So in the home setup. So I think that's one. Very funnily, when you look at also resources, it's also about technology. Today, all the technology people are getting sucked out, right, into the big startups. It's usually all about, the Netflixes and something else in those sectors. And if I have to run an ML model, with the data I have, it's very difficult to get people to even build out the technology. And that is one, so it's, resources obviously one. I think the other things which are the challenges are that people have expectations, right? So you have a lot of unusual expectations saying that I want a trained person, but I don't want to pay more than what I'm paying from the Nukkadwala agency who's giving it, right? So how do you expect a good person with that sort of training to actually come out there? And I think that is where that's another challenge that we have, that I think people need to actually think through this a little more and say that what is it that I'm actually getting it for, right? And how to actually get the best care that I can for my mother or father. And I think the next one is that a lot of people think that not to be, home care and elder care is not really, it is more of the wellness side. So let me not spend too much on that. I will rather keep aside 10 lakhs for the time when my mother needs to go to the hospital, but I'm going to nickel and dime for every small little thing, right? So I think it is to be able to, for people to realize that if you are a little more thoughtful and getting all your tests done, and tests are, people for me and, all of us to do the right tests at the right time on the wellness side, just so that you don't have huge episodic issues later on. I think that mindset also needs to change, but that's, I think, a very difficult one that would happen. I think these are the few, challenges that are there. We just have to work around these, chirag.
Thank you, Pradeep, for your insights. Our next question from the audience poll is to Nanki. So we have skilled attendants in senior care and home care. How can they be certified? Over to you, Nanki.
Okay, so I'd like to go back to what Pradeep actually said. First of all, we have skill, and how skilled are they? There are agencies out there that basically just say that they are experienced or they have skill, 4 or 5 of them, 4 or 5 days. So I don't know. I think the first thing that we need to do is figure out the level of that skill. Maybe have a common, once the Allied Healthcare Bill becomes a law, which I believe it isn't as yet, maybe we have a common entrance test, a simple test, so that everybody can be certified. That, okay, you are actually a caregiver and you have X number of experience and you have been trained. That way, everybody who is a caregiver ends up having the backing of the government, or that one certificate that goes in. That's one. That will also make verification easier. Like I said, you go into people's houses, what's your background, your police verification, all of that will end up becoming an easier task. Less of a liability for players like us, because it is an operational liability when somebody goes in, take care of a senior citizen, right? So I think it's a combination of a few things, right? And it means look at the current assessment, do a reassessment, let everybody enroll for that exam or that certification. Keep it simple, keep it easy, keep it like an online test. I don't know, like a CAT entrance exam, or have certain days in the week, or maybe once a month, everybody needs to go in there and get yourself certified. And that's common for everybody, and it's a very common practice to follow. And I would love to hear Professor Ajay's thoughts on that.
So absolutely, yeah. So any thoughts on that, Dr. Ajay?
So sorry, I missed the last point.
I was saying that having a common exam for
So
you to come and
the
get certified.
common exam is something which is it's a standard practice across in the medical profession. If you take the nursing or allied professionals, that is something which we can replicate. In addition, I would suggest having the CME programs, repeat certifications, and within those professions, having a professional body trying to ensure quality and competence among this staff or this cadre could be a practice that can be taken forward. For example, in many in the Europe or in the Western countries, the self-regulation is the norm within many of these professions. So some proven models could be used than reinventing wheels.
Thank you, Dr. Ajay, for your insights. The next question, I think it is in sync with whatever you said right now. It is for you, Professor Ajay. How can India quadruple its specialist while improving quality and pass percentage? And it's clubbed with another question. What can be done to promote hospitals as an academic center for learning and research? Over to you.
Yeah, so while acknowledging the fact that we don't have enough specialists, the issue is that even after quadrupling the numbers of specialists, we may not achieve the objective. Reason being, the specialists are concentrated in the urban areas or metropolis, because the facilities that are required for the practice are available only in these metropolis. So there is the requirement of government intervention. So the government need to put the systems in place for at least at the district level for facilitating the specialists to come to these areas, rural areas, practice. And government can also ensure higher pay for specialists. They need to have a specialist cadre in every state, standards followed across the states. And there could be incentives for private sector to offer specialist care in rural areas. So I would address that question in that way, because the issue what we are facing is quality versus the numbers and the geographical the imbalance. So we need to address the imbalance by having enough infrastructure and motivation for the doctors to specialists to come to the rural areas. Coming to the second question, how to promote hospitals, there are many opportunities for that, linking these hospitals with academic institutions, having standard teaching procedures, building international or exposure to national and international best practices, having online collaborations with national institutes of excellence or foreign institutions, building online resources, then a requirement of undergoing CMEs, building a good academic culture. So these are some ways of improving or promoting hospitals as academic center. There are proven models in India as well, because many of the good private hospitals, the tertiary care hospital, they are offering dependent programs. And we could take those examples for making hospitals and a good academic centers for learning and research. Over to you, Chirag.
Thank you, Dr. Ajay. The next question is for Pradeep. Pradeep, one or two policy changes that can catalyze upgrading the human resource home healthcare industry.
Chirag, that's a simple one, right? Because, sorry, can you hear me?
Yes.
Yeah, so that's a simple one. The reason is there is a home healthcare association, and I think these are the few things that they are working on, right? So the first one I think is, is what Nanki mentioned, saying that there needs to be a certification process for people, and that will actually make sure that people are getting the right level of care, and people will, others will feel comfortable handing over their parents to a certain professional company to look after them, right? And I think that certification process is something that's critical. The second is that you need insurance to come in, and insurance comes in, and with the certification, and suddenly that will open up a bigger market. There'll be more people interested in it. There would be this, there are people who like to stay on in a hospital today because they get insurance. They don't like to go home, so it's also clogging the hospital system. So insurance is number two. And last is the GST regime, which is, if I have to have, as a professional company, provide services of an attendant into a family, it is an 18% GST, right? And you're sort of competing with a Nukkarwala agency who is basically doing it in cash. It becomes a huge jump because we have a little bit of a markup, we are a little more expensive than the local agency, plus there's GST, and then people will say, oh, let me just go directly and get it from the woman who is local. But what they lose out on is all the training, all the different ways of doing things as a result of that. So it is insurance, certification, and better GST regime is what I think.
Thank you, Pradeep, for your insights on that. So we move towards the end of the program right now. So we have a last question, which is directed to Nanki. So can you give your insights on the discussion and the opportunities on the Allied Health Worker Bill?
The bill is actually with all good intentions. I think the government is finally moving forward. But I would like to see how is it implemented, Chirag. I think I really hope it's implemented in the spirit of what it is. And I mean, there are clauses like there'll be penalties if you don't register. That is great, but the process has to be easy. The outline has to be easy. You have to make it easy for people to go ahead and become a part of the system. You have to have the right narrative. You have to inspire them, right, that they want to be a part of that system. Otherwise, you will always have the formal sector, and then you will always continue to have the informal sector in the caregiving market, especially given the absence of any financial help. So I would just say one thing: implementation will be key. And I really hope somebody out there is really experienced and has his mind and heart in the right place as we roll out implementation of this bill.
Thank you. Thank you for the insights, Nanki. So as we move towards the end of the program, so just one question has come up. This one's for Dr. Ajay. How successful can be the district hospital in being converted to medical colleges? Over to you, Mr. Ajay. Dr. Ajay, sorry.
Yeah. So the converting around 75 district hospitals into medical college hospitals That proposal came in 2018 and 2019, and that was implemented in 2 phases. So as far as I know, around 40 hospitals have been converted into medical colleges, but the success is yet to be evaluated. The brighter side is that hospitals, the infrastructure improve. There will be minor HR improvements as well. They will get more doctors, but I don't think that has improved the quality of medical education, because the systemic issue is that we don't have enough medical faculty in our country. We have, as per the National Medical Commission's website, we have around 96,000 professors in the medical colleges, and the usual practice is that transfer some of the faculties from the medical colleges to this district hospital. So it dilutes to one point or the other. So that's the issue. So it needs more time, because we need to wait to get more faculties in this country so that they are adequately placed to have good quality education, including in these new district hospitals which are being converted into medical college. Over to you, Chirag.
Thank you, Dr. Ajay, for your insights. So we are at the end of our expert series. I would like to thank all the eminent speakers, the audience, for being with us. I would also like to thank Jayata and the team and the AVN team for making it happen. The video for the expert series are available in our YouTube and Facebook handles, those who can not make it, who did not make it on live with us. Lastly, we would like you to join with us in the next expert series coming next week. I am Chirag from the Western Region lead from NATHEALTH, signing off. Thank you all. Thank you. Thank you.